Parkinson disease. Parkinson disease is a common, progressive neurodegenerative disorder that affects aging adults. It causes a collection of symptoms known as Parkinsonism, characterized by tremor, rigidity, slowed movement, and postural instability. Parkinson disease is caused by degeneration of dopamine-producing neurons in the substantia nigra. The substantia nigra is part of the basal ganglia in the midbrain and can normally be identified grossly by its characteristic dark appearance due to neuromelanin pigment. Degeneration of these neurons leads to progressive deficiency of dopamine, a neurotransmitter that is vital for control of voluntary movement. Normally, dopamine is released by the substantia nigra to other parts of the basal ganglia, which, in a series of complex pathways, regulates activation of the thalamus and eventually results in stimulation of the motor cortex. Loss of dopaminergic output disrupts these pathways, ultimately increasing inhibition of the thalamus and decreasing activation of the motor cortex. This leads to the characteristic Parkinsonian motor symptoms. The mechanism underlying this neurodegeneration is thought to involve several factors, including aggregation of a protein called alpha-synuclein. This protein is normally expressed in presynaptic terminals throughout the brain and participates in synaptic function. Under certain pathologic conditions, such as oxidative stress or a mutation in the alpha-synuclein gene, it misfolds and aggregates into neurotoxic fibrils. Aggregates of alpha-synuclein deposit in intracellular inclusions called Lewy bodies, which can be seen microscopically as round, pink inclusions in the neuron cytoplasm. In addition to the substantia nigra, Lewy bodies can be found throughout the central and autonomic nervous system in Parkinson disease. This extensive involvement likely disrupts additional neurotransmitter systems besides dopamine and accounts for the wide range of potential motor and non-motor symptoms, as we'll discuss later. The underlying cause is often unknown and likely involves the interplay of genetics and environmental exposures. Several risk factors have been identified. The biggest risk factor is advancing age. The average age at diagnosis is 60 years old. Although most cases are thought to be sporadic, genetics can also contribute to the pathogenesis, especially in younger patients, and include mutations in the alpha-synuclein gene. Finally, many environmental risk factors have been identified, including exposure to certain toxins like pesticides. Parkinson disease is often thought of as a movement disorder. However, the clinical manifestations are wide-ranging and include both motor and non-motor symptoms that follow a predictable pattern of progression. Let's begin with the cardinal motor symptoms, which typically emerge after more than half of the substantia nigra dopaminergic neurons have been lost. These symptoms can be remembered using the mnemonic TRAP. Tremor is the most recognizable symptom and is the presenting finding in most patients. It typically begins in one hand and progresses to the other side over time. The tremor is resting, meaning that it occurs when the body part is relaxed, and decreases with voluntary movement. It's described as pill rolling, as if the patient is rolling an invisible object between the thumb and fingers. R stands for rigidity, or increased resistance to movement, which also usually begins unilaterally. During physical examination, passively moving the limb shows either cogwheel rigidity, like a ratchet, or lead pipe rigidity, meaning the resistance is constant and smooth. A stands for akinesia, which is the absence of muscle movement, or bradykinesia, which is slowness of movement. Bradykinesia is the most characteristic feature of Parkinson disease and is eventually seen in all patients. Patients may have difficulty initiating movement, such as rising from a chair or performing routine tasks. Other manifestations include decreased facial expression or a short, shuffling gait. The final cardinal symptom is postural instability, which is typically seen later in the disease. It's caused by impaired postural reflexes and makes it difficult for patients to prevent themselves from falling when thrown off balance. Other motor features, which often result from the cardinal symptoms, include stooped posture, drooling, and dysphagia. Non-motor symptoms affect almost all patients and can significantly impact quality of life. Common symptoms include autonomic dysfunction, such as constipation or orthostatic hypertension, sleep disturbances, and olfactory dysfunction. These symptoms can arise years before the cardinal motor symptoms and are caused by widespread alpha-synuclein aggregates involving areas like the sympathetic ganglia, brainstem, and olfactory bulbs. Other non-motor symptoms include cognitive impairment that worsens with disease progression, as well as psychosis and mood disorders, such as depression and anxiety. The diagnosis is made clinically based on the presence of cardinal motor symptoms and other supportive features, as well as the exclusion of other causes of Parkinsonism. This includes secondary Parkinsonism due to medications, as well as Parkinson plus conditions that share Parkinsonian symptoms but have additional findings. Beyond clinical examination, the most important supportive evidence is a dramatic response to dopaminergic therapy, which we'll discuss next. Currently, there is no therapy that can cure or slow the progression of Parkinson's disease. Treatment instead focuses on managing both motor and non-motor symptoms and improving quality of life. We'll focus here on motor symptom management. The motor symptoms are primarily treated with dopaminergic therapies, the most common and effective of which is levodopa with carbidopa. Dopamine itself is unable to cross the blood-brain barrier. Levodopa, on the other hand, is a dopamine precursor that can cross and is then converted to therapeutic dopamine by neurons. It's given with carbidopa, a peripheral dopa decarboxylase inhibitor. This keeps levodopa from being converted to dopamine in the peripheral tissues, which not only increases levodopa bioavailability in the brain, but also prevents adverse effects of systemic dopamine. It's important to note that levodopa has a very narrow therapeutic window. Too little leads to poorly controlled symptoms, but excess leads to increased stimulation of motor cortex and involuntary movements known as dyskinesia. Over time, the window becomes even narrower, leading to fluctuating periods of dyskinesia that alternate with worsening bradykinesia. This is usually managed by adjusting the levodopa or by adding other drugs such as catechol O-methyltransferase inhibitors, which delay levodopa's degradation and prolong the therapeutic effect. Other treatment options for motor symptoms include dopamine agonists, which improve motor symptoms by activating striatal dopamine receptors, and monoamine oxidase type B inhibitors, which increase dopaminergic activity by inhibiting dopamine catabolism at the synapse. Deep brain stimulation can be used for patients with medically intractable symptoms by using electrical stimulation to disrupt the pathologic signals in the basal ganglia. It usually targets the subthalamic nucleus or the globus pallidus interna, reducing inhibition of the thalamus and re-enabling motor cortex activation. The rate of progression varies significantly, and while treatment can improve symptoms, quality of life is invariably affected. On average, Parkinson's disease leads to loss of independent function within 7 years of diagnosis. Life expectancy is modestly decreased, and aspiration pneumonia is a common cause of death. To sum up, here are the key points to remember. Parkinson's disease is a progressive neurodegenerative disorder affecting aging adults and is the most common cause of Parkinsonism. It results from degeneration of dopaminergic neurons in the substantia nigra, leading to dopamine deficiency. Dopamine loss disrupts motor pathways in the basal ganglia, resulting in the classic Parkinsonian symptoms. Key pathologic features include depigmentation of the substantia nigra and the presence of Lewy bodies throughout the nervous system, which represent alpha-synuclein aggregates. Patients have characteristic motor symptoms including tremor, rigidity, akinesia or bradykinesia, and postural instability. Almost all patients have non-motor symptoms too. The diagnosis is clinical and requires differentiating Parkinson disease from other causes of Parkinsonism. Treatment has little effect on disease progression, but can improve quality of life. Motor symptoms are primarily managed with dopaminergic therapies like levodopa.